Good morning. This is Aslam Khan, Professor of Medical Surgical Nursing. Today we are reading about Parkinson disease. Parkinson disease is a neurological disease. We see the definition. Parkinson disease is a disease of the basal ganglia characterized by slowness in the initiation and execution of movement, increased muscle tone, tremor at rest, and impaired postural reflexes. So, slowness in the initiation and execution movement is also known as a bradykinesia. Increased muscle tone is a muscle rigidity, and also there is tremor at rest. If we see the causes of Parkinson disease, there are several causes which are chemical causes. Many chemicals, including carbon monoxide and manganese, among copper miners and the product of meperdine analog synthesis is the chemical causes for Parkinson disease. There is also chance of heredity. It may be drug related. Various drugs like ripine, methyl dopa, lithium, haloperidol, and chlorpromazine for prolonged use may increase the chances of Parkinson disease. Other causes include hydrocephalus, hypoxia, infectious disease of the brain like encephalitis, stroke, trauma, head injury, and tumor of the brain. These are the few factors, or we can say causes, of Parkinson disease. If we see the pathophysiology, due to this all etiological factors, as I said earlier, like heredity, chemicals, use of drugs like haloperidol, chlorpromazine, head injury, infectious disease of the brain. There is degeneration of the dopamine producing neurons in the substantia nigra of the midbrain, which resulted in clinical manifestation of extrapyramidal motor system. This dopamine is responsible for posture, gesture, and movements. Degeneration of this dopamine producing neurons may defect the postural changes, and there is difficulty in movements also. Next we'll see the clinical manifestation of the Parkinson disease. The clinical manifestations are varies. So many manifestation of Parkinson disease. The classical manifestation are three, that is tremor, rigidity, and bradykinesia. Tremor often is a initially first sign which is noticed by the patient. This tremor can affect handwriting. This tremor is more prominent at the rest, and this tremor is exaggerated by emotion, stress, and while patient is strive for increased concentration. This hand tremor is described as a pill running because the thumb and forefinger appears to move in the rotatory fashion as if rolling a pill, coin, or other small object. Tremor can also involve the diaphragm, tongue, lips, and jaw, but barely causes shaking of the hands. Second one is rigidity. Rigidity is second sign of the trade and is the increased resistance to passive motion when the limbs are moved through their range of motion. Parkinson rigidity is typified by a jerky quality. Parkinson rigidity is also elicit a complaint of muscle soreness, feeling tired and achy, or pain in the head, upper body, spine, or leg. Another consequence of rigidity is slowness of movement because it inhibits the alternating of concentration and relaxation in opposing muscles group like bicep and tricep. Other manifestation is bradykinesia. Bradykinesia is particularly evident in the loss of automatic movements, which is secondary to the physical and chemical alteration of basal ganglia and related structure in the extrapyramidal portion of the CNS. In the unaffected patient, automatic movements are involuntary and occur subsequently. It includes blinking of the eyelids, swimming of the arms while walking, swallowing of the saliva, self-expression with facial and hand movements, and minor movement of postural adjustment. The patient with Parkinson disease does not execute these movements, and there is also lack of a spontaneous activity. There is also stooped posture, masked face, like there is no expression, drooling of the saliva, and shuffling gait. These are the characteristics with this disease. The posture is that of slowed old man image with the head and trunk bent forward and leg considerably flexed. So these are the few clinical classical manifestation of Parkinson disease. Mainly manifestation as tremor, bradykinesia, and muscles rigidity. The complications of Parkinson disease are many, including the motor sign of Parkinson disease, and even non-motor symptoms are also included, which are depressions, anxiety, apathy, fatigue, pain, constipation, impotence, and short-term memory impairment. As the disease progresses, complications increases. These include motor symptoms, dyskinesia, which is spontaneous involuntary movement, weakness, akinesia, total immobility, neurological problems like dementia, and neuropsychiatric problems like depressions, hallucination, psychosis. Usually, dementia occurs in 40% of cases. There is also dysphagia. Patient is having difficulty in swallowing, resulting in malnutrition, or also there is chances of aspiration. General debilitation may lead to pneumonia, urinary tract infections, and also skin breakdown. Orthostatic hypotension may occur in some patients, and along with loss of postural reflexes may result in fall or other injury. There is also sleep disorders in patients with Parkinson disease, and the sleep disorder may be severe sometimes, and sometimes it's not be recognized properly. So this is very important for nurses, that there should be proper assessment of sleep pattern. These are the few complications of Parkinson disease. Next we'll see the Diagnostic studies. What are the diagnostic studies? Patient with Parkinson disease. Mainly, the diagnostic studies include history and physical examination. In history, we can ask about the patient's diet, medications, any injury of head, or there is a history of stroke, or there is family history of Parkinson disease. And if we'll to go for physical examination, we have to go for head to toe examination. We have to see gesture, we have to check patient gesture, posture, and we have to see the patient is having tremor or not. The classical manifestation of Parkinson disease, as I said, tremor, rigidity, and bradykinesia. These are the classical manifestation of Parkinson disease. We will also give the to see the patient response, positive response to anti-Parkinson drugs. Will give. We will also go for MRI to examine cognitive dysfunction in patient with Parkinson's disease. Next, management, collaborative care. As we know, for Parkinson disease, there is no cure. There are some drug therapy for Parkinson disease is aimed at correcting imbalance of neurotransmitter within the CNS. Anti-Parkinson drug either enhance the release of supply of dopaminergic or antagonize or block the effect of overactive cholinergic neurons in the striatum anticholinergic. Levodopa with carbidopa is often the first drug to be used for Parkinson disease. Levodopa is a chemical precursor of dopamine adrenergic and can cross the blood-brain barrier. It is converted to DA in the basal ganglia. Beside of this, cinnamon is the preferred drug because it also contains carbidopa, which is an agent that inhibits the enzyme dopa decarboxylase in the peripheral tissues. Dopa decarbonylase break down levodopa before it reaches the brain. This results in the combination of levodopa and carbidopa. So more levodopa, carbidopa reaches to the brain. Carbidopa and levodopa is also available in the form of tablet that rapidly dissolve in the mouth. This levodopa and carbidopa can be given with or without water. Apart from this, anticholinergic drugs are also used to manage Parkinson disease. These anticholinergic drugs act by decreasing the activity of acetylcholinergic, thus providing balance between cholinergic and dopaminergic actions. Antihistamines like dinephredimine with anticholinergic properties or beta-adrenergic blocker like propranolol are also used to manage tremor. The antiviral agents amantadine is also an effective anti-Parkinson drug. This amantadine promotes the release of dopamine antagonists from neurons. Besides of this, salicylanes, a monoamine oxidase inhibitor, that is sometimes used in combination with cinnamate. This inhibits MAO, the degenerative enzyme of dopamine. The level of dopamine are increased. Apart from this, racine, a type of BMAO inhibitor. This is a new drugs which is used in the treatment of Parkinson disease. Apart from this, we are also used the entacapone and tolecapone, which block the enzyme catechol-methyl transferase, which break down levodopa in the peripheral circulation. This promoting effect of cinnamate. Sometimes excessive amounts of dopaminergic drugs can lead to paradoxic intoxication. So most prescribed drugs is a levodopa for Parkinson disease. The mechanism of action may convert to dopamine in basal ganglion, which result in relieved symptoms like bradykinesia, tremor, and rigidity. So we also use in combination of levodopa and carbidopa. Apart from this, we use bromocriptine, mesylate, bromopyrrole, ropinirole, amantadine, and apomorphine. These are the dopaminergic drugs we are using for Parkinson disease. Anticholinergic drugs like trihexylphenylpheniramine, benzotropine, and bifenthrin. How it works, mechanism of action is it blocks cholinergic receptors, thus helping the balance cholinergic and dopaminergic activity. Relieved of symptoms mainly by like tremor. Antihistamine drugs we are using, that is diphenhydramine, it has anticholinergic effect. Apart from these, this collaborative therapy also include surgical therapy. Surgical therapy aimed at mainly we are using to relieving the symptoms, and I usually use in patients who are unresponsive to drug therapy or who have developed severe motor complications. Surgical procedure fall into three categories, that is ablation, dissection, DBS, and transplantation. These are the three categories of surgery. So first ablation, that is dissection. The surgery involves stereotactic ablation of areas in the thalamus, thalamotomy, globus pallidus, pallidotomy, and subthalamic nucleus, that is subthalamic nucleotomy. From last many years, this ablative procedures we are using. Second surgical therapy is DBS, which involve placing an electron either in the thalamus or global pallidus or subthalamic nucleus and connecting it to a generator placed in the upper chest like a pacemaker. The device is programmed to deliver a specific current which result in better response. This device programmed to deliver a specific current to the target brain location. Like ablation procedure, DBS can be adjusted to the control symptom better and is reversible. The device can remove the ablative and DBS procedure work by reducing the increasing neural activity produced by DA ablation. This DBS surgery been shown to improve motor function and reduce dyskinesia and medication usage. Transplantation of fetal neurons tissue into the basal ganglia is designed to provide DA producing cell in the brains of patients with Parkinson disease. This form of therapy is still in the experimental stages. Nutritional therapy is also very important because patients with Parkinson disease having malnutrition and constipation, these are the major and serious issues due to the inadequate nutrition. Patient who has dysphagia and bradykinesia need appetizing food that are easily chewed and swallowed. The diet should contain adequate rough and fruit to avoid constipation. Food should be cut into bite-sized pieces before it's served. It should be served as a warm plate to preserve in the peel. Nutritional management also include 6 small meals a day, which is less exhausting than eating 3 large meals a day. Ample time should be planned for eating to avoid frustration and encourage independence. In addition to absorption of levodopa can be impaired by protein indication and vitamin B6. So some patients are advised to limit their protein intake to the evening meal to decrease the problem. And there is also fortified meals, fortified meals and cereals. So this is all about the Parkinson disease, which is neurological disorders having characteristic of slow motion, bradykinesia, rigidity, and tremor. These are the classical symptoms of Parkinson. There is no cure for Parkinson disease, so only we are using anti-Parkinson drugs, and there is we are using surgical dissection or deep brain stimulation of ventrolateral nuclei of the thalamus or postventral globus pallidus. Thank you. Theory.